Welcome back to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US. We are your hosts. I'm Dr. Amrit Bilku.
I'm Dr. Deepan Kaur.
Hi, I'm Dr. Ravinder Randhawa.
And I'm Dr. Alex Kuhn.
Today, we're really excited to share an interview that we had with Dr. Richard Maharaj, a Canadian optometrist who has a special interest in dry eye disease. He is a clinical adjunct associate for the University of Waterloo College of Optometry, and he is the Canadian Association of Optometrists Section Chair of Ocular Surface Disease, the editorial board member for the Journal of Dry Eye and Ocular Surface Disease, the Chief Education Officer at mydryeye.ca, and the co-founder for the Canadian Dry Eye Summit, a national conference dedicated for educating eye doctors in the area of dry eye disease management. He also has been making YouTube videos since about 8 years ago, and his channel features awesome, informative videos that explain treatment methods for dry eye disease to patients. So these are all the reasons why we chose Dr. Richard Maharaj as the perfect optometrist to share all of his insight and knowledge and clinical experience treating dry eye disease in Ontario. We'd like to give a disclaimer that we did this interview over Zoom, and so there is a bit of audio lag or poor audio quality, so we apologize in advance for that. But other than that, we hope you really enjoy the episode. So sit back, relax, and enjoy the interview.
For you, how long have you been doing this now?
Since
The
March.
4 Eyes podcast.
Yeah.
No, really?
March, yeah.
Wow,
March,
good
or
for
we
you.
Launched. I mean,
Yes.
the planning and stuff was like in December, I think.
November 2019. Yeah.
When we launched, it was beginning of March.
Wow.
Basically right before COVID.
Yeah.
So, yeah.
This is great. Good for you.
Thanks. Yeah.
Good
I mean,
work.
yeah, and we're excited to, have you on here because, I think for ourselves, we wanted to make this podcast because we're still new grads. So obviously coming right out of school, I think we felt this kind of disconnect where we're not learning something new every single day like we were at school. And in our practices, we're probably seeing almost the same type of thing every day. So we're not getting a diverse experience in different areas of optometry. So we felt like this podcast was like the perfect way to get a really like a big variety of optometric topics, and then also to bridge the gap between Canadian and US optometry. Because when we were at ICO, I mean, the question was always, yeah, but what do you do in Canada if this happens? Or like, what do you have in Canada to prescribe? And, we didn't have those resources. So we need people like you to come on here and teach us everything you know so that we can learn too. Yeah.
And even on social media now, I feel like it's US optometrists that kind of take over the entire platform. So it's like people like you, like yourself, that are not highlighted, and we're like, no, these, you guys should be more or interviewed.
Yeah.
So
it's also, I mean, I think that's also reflected in the Canadian culture, right? I think the KOLs in Canada that are north of the border, and there's tons of us, not necessarily looking for a stage or a platform. And I'm not suggesting that the US counterparts are doing that, but there are more vocal, long-standing podium presenters out there that perhaps are just used to that. But the Canadiana, and what I've learned as well, just kind of speaking in Canada and the US, what I would say is that, Canadian CE in general, the learners there are truly there for the learning. And Canadian CE, whenever I've delivered it, I've noticed that the engagement is just different. I've always described some of the conferences I spoke at in the States, it always feels like it's a bit of edutainment. There's a bit of education, certainly, but there's a lot of entertainment kind of sliced in with that.
yeah.
But in the Canadian landscape, it may be a little, in some cases, it might be a little bit more bland, but it taps into what I consider to be true, evidence-based education. So that comes across as bland, but I think that's just the Canadian in us. So, we do it. We do it. We have fun with it, but, in our own little way. So I think that's our Canadian culture coming through. And I think that's something to be proud of too.
Fair enough. Yeah.
Yeah, that's actually so true, because I feel like the US is very it's very big and flashy, and they want to show all the cool gadgets and stuff that they have, and then Canada's all chill, laid back, sitting in the back corner, like,
Yeah.
you got that.
That's right.
Dr. Maharaj, for our listeners who might not know anything about you, would you mind please telling us a little bit more about yourself?
Sure, absolutely. So first, thank you for having me, and congratulations on your success so far. And so, yeah, I mean, I graduated, depends how far you want to go back, but I graduated in 2003 from Waterloo, University of Waterloo, and I practiced around the GTA in, I'd say, pretty much, at least at the time, every type of or mode of practice that was available. So I did retail optometry. I did refractive surgery consultations, dabbled a little bit in sort of a medical type of facility where it was a multidisciplinary medical clinic. And then I became kind of affiliated with refractive surgery centers, and I ended up sort of being a liaison at 3 major Toronto centers for quite some time, which is where I think I learned the majority of my cornea. You'd think you'd learn it in school, but you end up learning it on the road. So I spent a lot of time doing that. And while I was doing that, I joined a practice in Hamilton, a comprehensive eye practice in Hamilton as a co-owner. And I partnered there for about 5 years. So again, yet another sort of window to what I consider to be traditional optometry. I did that for 5 years. And at that point, I had an opportunity. The notion of starting a specialty clinic was brought past my desk, and I kind of looked at it. This was going to be and this would turn into be eyeLABS, obviously, but this started off as, okay, well, there's an ophthalmology presence here. There's space for an optometry presence. And so I pitched the idea of, well, what about if we didn't do just general optometry? What if we paralleled much more closely? We paralleled the ophthalmology center and kind of added complementary services, one of which was the ocular surface, right? And that was very much my experience when I did my rotations in the States, where optometry and ophthalmology were much more cohesive. It felt that way, at least.
Yeah.
So I wanted to try to recreate that. And anyway, so fast forward a little bit, that flew, and it turned out that within all the different niches that we had in the optometry side of that space, the ocular surface was sort of my area of interest, of keen interest, and it just kept on evolving. I completed my fellowship at the American Academy back in just when I opened the practice, so it all kind of lined up around the same time. And then since then, I've continued to do consulting and teaching and running this medical practice. It's a non-dispensing practice. We don't, there's no glasses there. We do dispense contact lenses and other specialty services, but we really try to, I say we, because it is a team effort. We really try to, what I think is create an image of what the future of optometry can hold. And I think we've done that reasonably well. And so I'm proud to, practice with guys like Dr. Vafai, Faran Vafai, and we've just added Dr. Karnvir Kamra and our newly graduated Dr. Diana Nguyen. So we brought on some people that are kind of like-minded and want to push the envelope a little further, kind of like you guys. So anyways, that brings us to today. And I do some other stuff with the Canadian Association, the Optometry Association of Ontario, and the Journal of Dry Eye and Ocular Surface Disease. So I keep my hands busy.
Yeah, you certainly do. Yes. So just to get things started here, so what does a typical dry eye workup look like at the eyeLABS Dry Eye Clinic? And what's your reasoning behind using the particular diagnostic tools that you use?
It's a great question. It's a big question.
Yeah.
And so I would say, what I'm about to say is more specific to what we use. And with the context that we're a referral-based clinic, so most of the patients that are referred to us have already had some type of, basic eye exam, if not advanced eye exam. So we run them through the gamut. We always start, and I think this is the most important thing, with a validated questionnaire. So whether that's the SPEED, the DEQ5, if we're doing a research, a study, where we'll use something like the OSDI, but we'll use a validated questionnaire. So generally speaking, you want to move from least invasive to most invasive, okay? Because obviously everything that you do becomes more invasive. So we'll start off with a questionnaire, then we'll initiate with tear chemistry testing, so like tear osmolarity and MMP9. We use both of those measures. Then we'll do a non-invasive tear volume test, so tear meniscus height. We've been using for the last 6 months a system called the dry eye analyzer, which actually is basically a slit lamp with a very slick module that has these tests kind of lined up. And it's wonderful, especially now we're in a post-COVID world where we can actually do all of these tests in one room. A report is generated that has all the results, and then it gets uploaded and sent to me in another room. So we're able to kind of socially distance, and I don't have to spend too much time behind the microscope, but we get all these tests. So anyways, tear volume, we do that non-invasively. Then we do a non-invasive tear breakup time. And the non-invasive tear breakup time is done with an infrared light source. So we're not inducing reflexive tearing. Then we actually introduce staining. Okay, so we'll do fluorescein and lissamine staining. So we'll still do an invasive breakup time measure, seeing as that we have the stain in the eye, to see how they correlate. And again, this is sort of more of a research interest rather than anything else. And then from that, we'll also capture some of the blink metrics, right? So how's the patient blinking? Is there microlag ophthalmos, right? Is there complete closure on blink? And then finally, the last thing we do is we measure meibography as well as the secretory function of the gland. So we actually do physical digital expression. And just to clarify, and for your listeners, digital expression with either your thumb or with a meibomian gland evaluator or with a Q-tip is not meant to be therapeutic. It's meant to be diagnostic. So you're just trying to release enough meibum from the gland to see what's coming out, and that's very different from what I would consider to be therapeutic expression. That's the workup, and that's kind of where it comes from. So it's a deep dive. We do a very, very deep dive. I want to capture as much information as possible.
Are there any certain dry eye diagnostic tools that are not available in Canada that you wish were available in Canada?
Yeah, you know what? There's one diagnostic tool, one little toy that I would love to see more available, and that would be confocal microscopy. I would like to, so the Heidelberg HRT has a corneal module that allows you to image the subbasal nerve plexus. So for patients that have, so I get, again, in our center, we get a lot of complex pain-related dry eye, right? So your neuropathy patients, your corneal neuropathy patients. So that is an area of keen interest of mine, just I guess because I've acquired a lot of patients that suffer with this. And I think what we're missing in that particular domain of ocular surface is the objective findings. And so confocal microscopy would allow for that, allow us to and if you look at any clinical study that anything from Pedra's study, for instance, his work, or Rosenthal, you'll look at the data that they've collected on the morphology of the corneal nerves, the subbasal plexus. There is a ton of information that can be gleaned from that. And more importantly, I think there's an opportunity for us to actually create some type of normative database, because not many people, not many academic centers actually have it. And those that do aren't using it routinely, right? You're using it on a clinical study, for instance, but it's not being done routinely. So we have an idea of what normal is. We have an idea of what abnormal is, but it's an idea. And, the distance between an idea and an actual concept, a theory, becoming manifest is the data between those 2 points. So I'd like to see more of that for sure. And then the other toy I'd love to see, and there's a company, I believe out of Japan, Tomy, I believe, they have a system that captures thermography. So it measures the temperature, at any given point on the eyelid, the cornea, and ocular surface. And thermography is actually quite interesting. And there have been some studies that have looked at thermology, and related it to dry eye, and helps to differentiate certain types of dry eye from, say, a raging bacterial conjunctivitis, for instance.
Based on
so I'd like to see thermography. Yeah.
Oh, wow.
And actually lid temperature. Donald Korb did some work with looking at, the lid temperature, temporal, central, nasal, and looking at sort of an average lid temperature, the spread of temperature from temporal to nasal. And so all these things actually do do make a lot of sense if you can measure it precisely and accurately. Yeah.
Oh,
It's really
that's
interesting.
something I've actually
Cool
never
stuff.
heard of, the thermography. I was wondering if that checking the temperature just helps you to determine if it's like an inflammatory cause or something else.
Yeah, you know what? At a very basic level, you're absolutely right. It
Okay.
can help you to differentiate, but there are actually some finer points of differentiation between the lids. So again, the delta in temperature from your temporal to your nasal upper lid, for instance, can be almost an entire degree. So if you've ever expressed glands, if you've ever expressed temporal central nasal glands with your thumb or a cotton tip applicator, you'll often find that the nasal glands tend to express the best. And that's because the central, your core temperature is always going to be highest in the center, even if it's a point or two above. And that, 0.5, 0.6 degree difference can be the difference between, the quality of meibum. Yeah, thermography is really interesting.
So the eyeLABS dry eye clinic, on the website, it does show that it offers a variety of advanced treatment options for mild to severe dry eye patients. And so with your clinical experience, what would you say are your most common or kind of like your go-to treatments for most of your dry eye patients?
That's a $1 million question. But it is a question that comes up often at every seat I'm at. Like, what would you go to, generally speaking? And so with context that I practice in Brampton, a lot of our local patients are South Asian, and our referred patients come from all walks of life. I can say that there is no silver bullet just because of that diversity. Having said that, what I would do is I would group treatments together. Okay, so I'd say that there are treatments or therapies that could be done on the glands, thermal or light based. So that's something like, say, LipiFlow or eyeLABS compared to, say, an IPL, for instance. Those are two different mechanisms. I would say gland therapy is by far the biggest part of my dry eye practice. Within that subset, then, I wouldn't say that I have a one or the other, because we're looking so closely at what the true etiology is. So for instance, if the patient has rosacea, I'm going to reach for IPL. But if they're South Asian, they can also have rosacea. It's just a lot harder to see it. Problem with IPL and the darker skin, the darker pigmentation, is that it absorbs more light energy. So we have to be careful with darker skin and using IPL. So in those cases, I might reach for something like a thermal option, like LipiFlow. Some colleagues use. I don't use eyeLABS. I've used it in the past. I'm familiar with it, but a thermal option might be more appropriate. So I would say that gland therapy in general would be the biggest part of my practice, juxtaposed to, I think, the most important other elements, which is, their at-home therapy, their non-preserved lubricants, their omega-3s, their, at-home lid hygiene. I've always described the treatment for dry eyes being like a table. You need to have 4 legs to that treatment table, right? If you just say, hey, we're going to use Restasis, then you rest assured that table is going to fall. You need to make sure you pair your pharmacy with your OTC, with your at-home OTC, non-drops, with your in-office therapy. I think those 4 things are paramount.
Yeah. You actually mentioned something that really connects with our episode that we did with Dr. Laura Perryman, because she also mentioned that, dry eye treatment, it's not just a one thing fixes all, because dry eye disease has many different mechanisms that causes it. So you need to hit all of those mechanisms, and it is going to take different methods to get there. You also mentioned the preservative-free eye drops. Now in Canada, we do have a few options for preservative-free drops. There's like the eyeLABS Duo, the eye drop, and then the Hilo. Do you tend to recommend any certain type of preservative-free drop for your patients, or notice that they respond better to certain types?
Yeah, I'm just going to circle back on one thing you just mentioned there about Laura. And yeah, Laura, I'll be the first to say that I've always been a huge Laura fanboy. I mean, Laura and I are ocular surface brothers and sisters, so we agree on a lot.
She gave a shout out to you in the podcast.
Oh well, shout out right back to her, because she's my hero for sure. I've learned a ton from her, and her passion for this subject is palpable whenever you just have a quick conversation with her, that she's in it for the right reasons. So
Yeah.
but I 100% agree with her. Yeah, you're right. It's her bestow analogy is great, and it taps into, I think, the exact cycles that any practitioner that's treating it needs to focus on. So to your question about the different non-preserves, in Canada we have a little bit more freedom with hyaluronate. So hyaluronate is a molecule that is very water loving, water attracting, and it also has a very unique behavior on the eye in that it's sort of a pseudoplastic, right? So it has this plastic-like behavior when there's not a lot of shear forces. So that's, blinking. And it has a liquid-like behavior when there's no shear forces around. So it acts like a liquid. So it's, in a sense, it's mimicking the tear film. And so I've always loved anything that's hyaluronate based. So in Canada, we have the offerings for hyaluronate are actually quite a lot more than when I just started eyeLABS. But we have, as you mentioned, iMed Pharma. They have their eye drop line, and they've recently launched eye drop MGD, which is a hyaluronate lipid agent as well. Then there's Labtician, who carries the Thalos line and the Hyaback line. They also have a Thalos eye gel, which is a night ointment, not an ointment, but a more viscous, a hyperviscous solution. And then you have Candor Vision producing the Hylo Dual and the Hylo Gel experience. Those are my staples, those three, those companies in particular. And again, I'm going to put disclosures out there because I think it's only important to do so. I've consulted with every one of those companies in the past, so I don't, yes, I have skin in the game, so to speak, but I gain nothing from putting one over the other. In my experience, I would say that there are certain cases where I will go even deeper into choosing this by looking at the molecular weight of the hyaluronate. iMed Pharma has a very high quality hyaluronate. Okay, so their molecular weight is a lot denser, which means that the residence time on the eye tends to be longer. And their new eye drop MGD, I'm pretty impressed with it. So I have MGD as well. I love that drop. There's something different about it, and you'd have to experience it yourself to understand that. But has longer residence time, doesn't blur the eye up. So I like that a lot for my MGD patients. The Thalos drop from Labtician, I like that a lot too for patients that have really high osmolarity, because it is bioprotectant. So if you think about, you're in Calgary, Deepon, right? So you think about your shoes in the winter and they get that salt around the edge, you want something to protect your leather so it doesn't erode. While the Trealo's that's in the Thalos line is just that, it's a protectant. So it helps to protect the tissues that are exposed to that hyperosmolar environment. So I really like the Thalos line. And then in the Hylo category, I've always liked their Hylo gel. For those patients, my elderly patients that have incomplete blinking, microlagophthalmus exposure issues, I tend to put them on that as well because it does have a longer residence time. The challenge with every one of these drops is the various bottles, the multi-dose bottles. So have you guys tried any of these so far?
So I've used Hylo. A lot of my older patients have trouble using the Hylo drops. They just can't seem to squeeze the bottle properly.
Yeah, it's tough, man. It's really tough for a person with arthritis. It's actually quite tough. So I think they all have their drawbacks. So I don't think there's a one size fits all. Again, that seems to be my quote of the day. But hopefully that description as to which ones I use when helps. And the bottle, you just have to spend some time with education. I've always said my staff and your staff will be the most important part of your team because they're the ones that are going to offer tips. It's kind of like a contact lens patient putting them in for the first time. How do I do it? How do I keep it in my eye? So you want your staff to be empowered to give them tips. How do you get the drop in the eye if they have a family member or relative that can insert it for them, for your elderly patients? I mean, there's options.
That actually does really help because I've tried a lot of different brand name eye drops like over the counter for dry eyes. And it's true, you really can feel a big difference with ones that absolutely do not work for you and ones that really feel good on your eyes. And even though they have very similar ingredients. So that's actually really helpful to know.
Thanks. Okay, so I know you kind of briefly talked about these two treatments. So For LipiFlow and the IPL treatment for dry eye disease, can you go into more in depth about your experiences in using these tools? Like, do you prefer one over the other in certain patients and things like that? And then specifically for IPL, do optometrists in Ontario need certain certification or training to use it?
So again, going back to what I was mentioning about LipiFlow and IPL, we'll just talk about those two because you brought them up, not because I have any preference. So I have always, so when we opened the clinic back in 2012, we were the first optometry clinic to own the LipiFlow system in Canada. So I have the most experience with that. So I use it a lot. I think it has great value in most patients that have MGD that have done nothing. So I was actually speaking to our fourth year clerkship student today, about why we don't go to a hot compress first. And that's because, again, most patients that are coming to us have already tried a bunch of stuff. But secondly, I know both clinically with my clinical experience, as well as through the massive amount of evidence in the literature right now that supports gland clearance as a more effective means of treating MGD. I know that LipiFlow is a better option. So I feel compelled to, recommend it when it's indicated, number one. And number two, not really, suggest to the patient, we get into, I'll tell you, this is a Canadian thing. We get too caught up with, okay, there's this treatment that's much better for you. It works way more. It's FDA approved specifically for your disease, but it costs this much money, or it costs more than a Bruder mask, for instance. And so I don't get caught up in that conversation. I don't even have the conversation about pricing. I tell them the options. I tell them what I know. I educate them, and our front team, our front staff, our concierge will go through costs, et cetera. So in my experience, LipiFlow has been godsend for many of my patients. It's been life altering for many of my patients early on. And so feeding on what I said earlier about skin type, so skin type will also help me to dictate who gets LipiFlow. So if the skin type is a darker skin type, so if Fitzpatrick, if anybody wants to know about skin typing, you look at the Fitzpatrick scale. So if Fitzpatrick 4 or greater, I typically will move to that patient to a LipiFlow procedure. If their skin type is lighter than that, it's not a slam dunk that I'm going to put them into an IPL procedure. But if there's obvious telangiectasia and rosacea signs, I'm leaning towards IPL. There are some cases where we need both, okay? Where, for instance, their MMP9 is through the roof. They have obvious rosacea, but they've also been on, say, Xiidra and Restasis for the last year, and nothing's working. In these cases, I will take a 1-2 punch. And going back to Laura's Besto analogy, that's in my opinion where IPL and LipiFlow tend to be actually complementary. So that's kind of how I look at things. So I look at skin type, I look at disease severity and disease etiology, and that helps to guide me. So it's not just, I'm not throwing a dart and saying, oh, today feels like an IPL day. To answer your question, Deepan, on certification, there is no requirement at this point to certify for the use of IPL in Ontario, and not any other province that I'm aware of. You can maybe speak to Alberta, but I'm not aware that there's any certification required, because it's the application. It's within our scope already, the application of non-ionizing radiation. So not at this point.
My next question is about amniotic membranes. So you use this for special cases of dry eye disease. Could you describe what special cases are most eligible for amniotic membranes?
So for amnion, there's two different types of amnion in Canada. There's dehydrated and cryopreserved. Cryopreserved being Procara, and dehydrated in Canada we have BioD. That's the only one that we have available now. In the States, you have a few more options. Indication, so I choose amnion in cases like, so for instance, filamentary keratitis, epithelial basement membrane dystrophies, corneal neuropathy. I'll reach for it because I've had good success with it, and there have been some papers showing clinical improvement in symptoms, right? And remembering neuropathy doesn't really have, certain cases of neuropathy doesn't really have robust corneal signs. So it's selection you have to be really careful with, but those are kind of like the areas that I use it the most. And obviously dense, really, 4+ FK, filamentary keratitis, bad corneas, graft versus host. If you can get that onto the eye, those are cases where it makes a lot of sense. In those cases, certainly I would actually get them into a scleral shortly thereafter. So in some cases, in those types of cases, GVHD, I'll put a Procara on, for instance, and I'll prepare that patient to eventually get into a scleral lens very shortly. So those are the applications. I mean, it's a great option. Again, I don't put my hands in patients' pockets and assume that they can or cannot afford. But in cases where it's obvious, and to me, those are like I said, the 4+ SPK, the filamentary keratitis, the GVHD patients. In those cases, I think that this is a clear indication. I've even had, I think I published a report on a patient that had HSV keratitis who had some stromal scarring, and we caught a second recurrence, I believe it was, or a third recurrence, right in the nick of time. We got a membrane on that, and we actually were able to reduce the stromal scarring that was there previously. It was recent stromal scarring, but we were able to reduce that, and the patient's VA improved, and we got into 20/25 plus or 20/20 minus. So I think there's other indications in certainly in your ulcers and things of that nature, depending on where you are. But yeah, that's kind of how I use it in practice.
How long does one treatment with the amniotic membrane tend to typically last for your patients in terms of reducing signs or symptoms?
Again, very good question. I think it depends on the severity or what the cause is. So for instance, for advanced dry eye, I would say that I've by and large, I've been able to, if that's one, leg of the table, so to speak, I've been able to do one and done in many cases and just kind of rehabilitate the surface, get everything else working, and that's it. There have been some cases where, these, again, recurrent erosions where we might have had to repeat it a year later. I don't think I've had a case where I've had to repeat it sooner than a year.
Oh, wow. Okay. Well, that's
good.
That's
been my experience. But again, I'm very aggressive at treating everything else.
Yeah.
So it's like I said, it's not just a one and done.
Yeah, it's more of like a supportive therapy for everything else that you do, pretty much, right?
Yeah, the analogy I give is like, look, if you have a fire, you want to put that fire out. So I think the amnion is like putting a water blanket on that fire. Then it becomes easy to kind of just douse a little bit of water, sprinkle some water in after, put some soil in it after, cover it up to get that fire out completely. But I think that initial water blanket is the most important thing. That's how I see amnion fitting into our arsenal.
Yeah. And then, since I think amniotic membrane treatment is probably pretty costly, do Canadian insurance companies ever tend to cover either an amniotic membrane treatment or any dry eye treatment, either fully or partially in any type of situation?
So our, insurance has been very, very slim to none in terms of what they cover for ocular surface. In certain, workplace insurance cases, so if the patient has an injury on at work and they have a corneal, abrasion that requires an amnion, then in those cases there may be some coverage. But in my experience, it has been very, very minimal. Again, I'm in Ontario, so I'm speaking specifically to the Ontario experience. I do know that some more comprehensive insurance plans, will some patients have received coverage for a portion of LipiFlow, but not yet IPL.
And then how about with the government, so universal health insurance, like specifically in Ontario, OHIP?
So if you're seeing me, you're seeing my face twinge a little bit here, right? Talking about OHIP in Ontario. Yeah, universal is not that universal.
Yeah.
Right now, especially in Ontario, we're in the midst of job action, so it's that hopefully paints a picture for the audience that we're grossly underfunded. But speaking generally, there is no provisions for dry eye specific services, no matter how medically necessary it is.
I think they've been trying to get these kind of procedures covered for a while now. I've been hearing about it since before I started optometry school, and I don't think we've inched any closer to getting those kind of treatments covered by.
Yeah, you kind of have to be careful what you ask for, right? Because look, I could speak to Ontario. Ontario, at some point, we had coverage that was comparable to the cost of providing those services, but we are locked into this sort of prison right now where we have no capacity to recover our costs over and above what OHIP provides. So, it seems noble to ask government to help for these procedures, but I would argue that number one, it's probably not a good idea because I don't think they have the closest understanding as to what the costs are to provide. And then number two, they have full capacity to dictate what they charge, whether it covers your costs or not. And for Amrit, for you, being in the States, you probably know full well that is a major problem when you have a third-party insurer. In our case here, that insurer is the government. When you have a third-party insurer dictating what they will cover and that you can't charge above that, that becomes a loss leader, and that's not something that we want to get involved with. So I think we have to be careful, personally.
Yeah. And so we'll talk about your surgical patients. So how involved are you in co-managing patients with dry eye disease who are undergoing ocular surgery, like LASIK, cataract, glaucoma surgeries? Do you stay in touch with the surgeon to discuss pre or post-surgical results?
The surgical conversation and the ocular surface for me is a hill that I'm willing to die on. So I've said this from day one. This is exactly where optometry can excel and should excel. Handing that patient over to your surgeon, you should hand that patient over prepared for surgery, which means preparing that ocular surface. So in my facility, we have an extensive preoperative preparation program where we make sure their glands are optimized, their ocular surface is optimized. Giving Laura a shout out, she's like, we're sending our patients for premium IOL, which is like, a high-end race car. We want to make sure they have an engine to support that. So whenever I'm sending a patient for any inflammatory event that I know that my patient's going to undergo, I want to make sure that their ocular surface is prepared to handle that insult. Again, we've been doing it for a while, so we actually kind of have the reverse happening where we have ophthalmology sending to us to have those patients prepared for surgery, particularly the more complex corneas. We will optimize that surface prior to surgery so that their biometry is accurate, right? Look, these patients are paying for a premium IOL, several thousands of dollars, and you have a foggy window that they're going to look through. That's not the best scenario. If you have a difference in dioptric value of an IOL, that's going to amount to several diopters of refractive error, of a refractive surprise that no surgeon wants. The role of optometry, in my opinion, when it comes to that surgical space, is the peri-surgical time, right? So, a little exercise. This is something that I kind of grabbed from doing any type of mindfulness training or anything like that. There's an old Buddhist parable. It's a story about this man who's just kind of standing in the field, and he gets shot in the heart with an arrow, a poisoned arrow, and by some guy on a horse. And so the village people kind of gather around him. They get a surgeon, and the man who's dying starts asking, well, what was the name of the man and the horse? And what kind of wood did he use in the shaft? And what was the name of the horse? What direction was he traveling in? And all these sorts of questions that have nothing to do with the fact that the arrow needs to be removed, right? So unfortunately, this man has no concept of what he needs to know. The surgeon knows what he needs to do, but there's a space between what he needs to know and what the surgeon needs to do, which is, I believe, where we come in, right? So we need to fill that gap. We need to somehow tie the patient to their endpoint, whether it's surgery or whether it's treating the dry eye or whether it's treating their vision therapy or whether it's treating their glaucoma. We are the space between. We are equipped with the information and the education to be able to kind of point them in that direction. So I think that pre-surgery, that's a space that we need to be, I will say, we need to be better at that.
So I really agree with you there. I feel like collaborating with ophthalmologists is really important, especially for me. I feel like that just really gets the patient the proper care that they need in all aspects of their, ocular health. And that kind of leads into the last topic that we wanted to ask you about today. So, dry eye disease is known to have some sort of psychological component. There's been reports that dry eye symptoms can lead to frustration, depression, and even suicide in some people. So have you ever come across patients that have been psychologically impacted by the disease? And if so, how are you approaching and managing this, area of dry eyes?
Every single day, right? So especially now we're post-COVID. So I've kind of opened up my specialty clinic to full-time. So every single day there is a patient that has some type of psychological component to their disease. In general, there is a high correlation between anxiety, depression, and dry eye. It's in the literature. Even if you do a cursory review of it, you'll find it. I have a few theories on that. I believe that a part of the disease is also neurological. It's neurotransmitter related. And so these patients that are, in an anxious state have a heightened sort of sense of anxiety, their neurotransmitters are firing like crazy. And they've probably been firing like crazy for a while. So it's no surprise to me that their corneal nociceptive endings are also being stimulated at a higher rate and are likely more susceptible to, quote unquote, injury or symptoms that are disproportionate to the signs. So I'd say that it's a huge component. So I'm also mindful of the fact that I'm not a psychiatrist or a psychologist, and I'm not about to diagnose anybody as having any of those things, but I am attuned to those patients. I've seen enough, and I am attuned to the fact that this patient is like the Buddhist parable, where he's worrying about the name of the man that shot the arrow into his chest and not the fact that the arrow needs to come out. So in those cases, I will certainly have the conversation with them about accessing help for their mental health. My wife's a social worker, so we've been married for 10 years. We have 2 kids. Mental health is a big part of our family discussion. So, I listen a little bit more. I think I listen better now than I did in the past. But I'm the first to kind of point them in the direction and make sure they're getting help. I think that we could all stand to sharpen our mental acuity, whether that's for, the reasons of managing a disease or whether it's just to be your best self. I think making that recommendation does not hurt, but you can be very specific in patients that have dry eye, that there is very likely a relationship there. So if there's one piece of advice I can give anybody that's treating this, that when you suspect it, talk about it to the patient, and within your own, context, determine if you feel as though that patient is safe for themselves, right? And then once you've done that, your job is done, meaning you refer them to get help. Don't try to help them yourself. You refer them to get help. We're not trained to do that. That's not our job. But make sure you have a team around you. You know where to send these patients to.
Yeah, I agree. That's why I feel like you brought it up perfectly. I feel like every time there's a conversation about dry eye disease, the psychological component doesn't really show up as often. And I felt like that was a really important thing to make sure that people know, to be more collaborative in your care and make sure that you're at least offering a referral or even mentioning it in your brochure pamphlets, when you're mentioning what dry eye disease is all about, so that the patient can also be aware that, some of my symptoms that I'm feeling might be from dry eye disease, and it all makes sense now. So yeah, thank you for that. That was great.
And you know what? I'll add one last little piece here. So our recently graduated former clerkship student, Diana Nguyen, she just started a blog and a Facebook group for patients called My Dry Eye Space. And the sole intention really is to give them a space to speak openly, to get, some guidance, not medical advice, but some guidance on, information that's out there, but to really give patients the space to have a conversation about their experience. Heartfelt kudos to her for doing that. And I think, my patient, I've pushed my patients to that, and they've started entering that group. So I would recommend anybody to listen to this, go to the Facebook group, My Dry Eye Space, and get your patients enrolled there.
Yeah.
Just have them sign up. They can share their stories. They can help other patients. It's about everybody helping each other. We're a large community, and technology's brought us a lot closer. So visit it, check it out. Really good.
It's good to have a space where everyone can kind of share their stories and their experiences so they don't feel alone. So that'll be really helpful.
I definitely shared my stories with Deepan, Rav, and Alex. They know how bad my dry eyes are, so.
Yeah.
It's amazing that we could feel alone in a world where, first of all, we're able to do what we're doing right now, but to me, sometimes it's sort of paradoxical that we could feel so alone in a world where we are more connected than we ever have been.
Yeah.
I find that to be really, really interesting and very telling.
Well, Dr. Maharaj, you basically answered all of our questions that we wanted to ask you. So did you want to add anything else to the conversation?
Well, thank you. First of all, I'll say thank you. It was great. I enjoy these conversations. I think that, again, what you two are or you four are doing in this podcast, I think it's fantastic. Having conversation, it's great. I'll put a little plug quickly for the Canadian Dry Eye Summit, which was previously a live meeting. It is now a virtual meeting, which will be taking place in November this year. And so we've changed it up. We're going to have more of a dynamic weekend event virtually where we'll have live demos. We'll have sort of faster paced CE. We're still making it accessible. So if you visit dryeyesummit.ca, that's where tickets are available, and they're on sale now, and it's in November, and it is a must attend.
But yeah, thank you so much for joining us today and sharing all the in-depth and insightful information that you had. And we really enjoyed it. And I'm 100% sure that our listeners will definitely enjoy what you had to say as well. So thank you so much.
Yeah, thank you very much.
Thank you both.
Thank you to everyone for listening to Four Eyes. If you enjoyed this episode, please be sure to subscribe and leave us a rating to give us feedback on how we're doing. You can also check us out on Instagram at 4eyesoptom for more content. Look out for new episodes every Wednesday. So until then, stay tuned.